And to guide us in this topic, today we have with us Dr. Madhvi Nori. She is a consultant radiology and director at Madhvi Scan Center and Vista Imaging, Hyderabad. And she specializes in gynec imaging and MRI. And she will guide us on the topic of imaging in endometriosis, ultrasound, and MRI. We welcome you, ma'am.
Thank you so much. Thank you for giving me the opportunity to interact with the fellow clinicians and students. And I'd like to start. I think it's 7 o'clock.
Yes, ma'am. We can start in. Yes, ma'am. We can start, ma'am.
Shall I?
2-3 minutes are there, but we can.
Okay. Okay, can I know, like, what is the mixture of the audience like? Are they practicing physicians or the students, or all are gynecologists, or are there imaging people also?
More of gynecologists, ma'am.
Okay, okay.
Ma'am, you can do full screen, ma'am.
Is this okay?
Yeah, it is fine.
Okay. Shall we start?
Yeah. Yes, ma'am, we can.
Good evening. And as introduced, the topic for today would be diagnostic strategies in endometriosis. I have titled it as strategies because imaging modalities are there, but we have to optimize it to answer our question. So the outline of the topic would be to have an overview about background on endometriosis phenotypes and diagnostic discrepancies encountered, revisiting anatomy with better understanding of the disease patterns, and thereby optimizing the imaging modalities by using strategies. The available diagnostic modalities in clinical practice are ultrasound and MRI. Once the imaging is done, conveying the findings using structured reporting using latest NCCN classification, understand pitfalls and controversies in endometriosis diagnosis, and look at the performance of individual modalities and surgical implication of the imaging findings. Finally, to have an understanding of a clinical algorithm in practice to decide and to refer for the imaging modalities. Now, if you look at endometriosis, it is chronic, incurable at present, estrogen-dependent inflammatory disorder characterized by endometrial-like tissue outside its usual location, and it is found mainly in pelvic organs and extrapelvic sites. Also, the prevalence of endometriosis is seen in 10% of patients. But the major challenge is endometriosis is diagnosed late and remains undiagnosed in a large proportion of women, which results in disease progression and negative impacts on health and well-being. Currently, the gynecologists rely heavily on laparoscopy to diagnose, which results in diagnostic delays of 6 to 11 years. Now, if you look at the spectrum of the lesions of the endometriosis encountered, they are heterogeneous and wide, ranging from superficial endometriosis seen as vesicular, different colored lesions on the surface of the peritoneum, to typical endometrioma as chocolate cysts, to deep endometriosis involving transcompartmental organs and adhesions, to complete pouch of Douglas obliteration. So this is the phenotypic spectrum of the range of endometriosis seen. And what we see in clinical practice majority of the times is discrepancy between the diagnostic performance and intraoperative findings. So what is diagnosed more easily is the chocolate cyst, which is typically seen as a ground glass appearance with a thick walled cyst. And this is the easier part of the surgery. And what goes unnoticed is this spectrum of varying ranges of deep endometriosis adhesions, which, if unprepared and entered into, it's very difficult, and this triggered our interest or my interest in imaging of this entity. So limitations of imaging perceived by the clinicians are it cannot rule out overall endometriosis. The diagnosis is dependent on surgical and histological diagnosis, and in absence of surgery, presumptive diagnosis is offered because of the fact that imaging cannot reliably pick up all the spectrum of endometriosis. Now, having seen the discrepancy between the performance and intraoperative findings, why and what can be done to bridge this gap? Up till now, and still majority of the places, pelvic organ scan is done by basic pelvic ultrasound as per AIUM guidelines, where you look for the uterus, ovaries, pouch of Douglas for fluid or mass, where you diagnose ovarian endometriomas and we finish the job. But we miss the other spectrum. So what can be done to diagnose this spectrum? It is the same machine, same probe, but you utilize the strategy and methodology to interpret the pelvic compartment anatomy, and it is well standardized. ISWOG approved IDEA consensus of deep endometriosis ultrasound is very reliable and reproducible method, whereby you not only look at uterus, ovaries, and pouch of Douglas, but you extend your scan to look for mobility, transcompartmental organs like bowel,
Recording in progress.
on ultrasound. So, what is required from perspective? It is understanding of anatomy and an acquaintance with the normal imaging appearance beyond traditional pelvic organs or genital organs, to be more precise, which will enable us to do precise reporting. So for that, you have to go beyond routine evaluation with the standard planes of section and be used to the normal landmarks to identify various ligaments and spaces, because this pathology or the pathological conditions affects the ligaments of female genital organs and pelvic spaces and change their imaging appearance. If you look at the pictorial representation of most common sites involved in pelvic endometriosis, the female pelvis as seen in a ventral view and lateral view, you see the involvement of pelvic endometriosis in a transcompartmental fashion. It involves not only the genital organs like uterus, ovaries, it also involves other organs of different compartments like bladder, rectum, and the spaces. So this forms the premise why you should revisit the ultrasound as seen by our clinical colleagues. The anatomical regions in female pelvis is divided into anterior compartment, middle compartment, and posterior compartment according to functional and clinical relevance. This compartmental view can be easily depicted and interpolated across the imaging modalities. Here we see the anterior compartment, middle compartment structures, and posterior compartment. So on a trans-abdominal scan, the same compartmental anatomy can be visualized in an axial section. This is the most anterior part of the anterior abdominal wall, bladder, middle compartment structures, and posterior compartment in an axial view and a sagittal view. The same can be extrapolated to MRI, anterior compartment structure, middle compartment structure, and posterior compartment structure. So, internal genital organs as seen on TVS. The female genital organs are positioned in central compartment in female pelvis. So, when you place the probe at the perineum before entering into the vagina, place the probe on the perineum and look at the perineal anatomy, anteriorly is the urethra. This is the perineal body on which you are resting the vaginal probe, and this is the posterior compartment structure. This is the anorectum. This echogenic structure is the puborectalis sling. So this essentially is the pelvic floor where you place the probe on the perineum. Now you start from the pelvic floor and introduce the probe, gently scrutinizing the vaginal walls for mobility. Then once you look for the mobility, you enter into the fornix. This is the anterior fornix. Once you place the probe, then you elongate your probe to understand the genital organ with respect to its version, axis. Then you look at the measurements from medial to lateral on a sagittal plane. So here we are. Once we finish the sagittal, parasagittal sections, you move your probe orthogonally from a caudal to cranial perspective to look for uterus in a caudocranial manner. After that, you move the probe in a lateral fashion to look for adnexa. And here what we see, once from the cornu, you can trace the uterine pedicle beautifully, which leads to the ovary in the lateral pelvic side wall. So each and every organ has its definite signature of anatomy, which with time and learning curve, you will have an idea about its normalcy. So the same procedure, you move to the other side, trace the cornual aspect of it. This will lead to the uterine ligament, which will lead you to the ovary. And here we see the follicular rupture from the left ovary. So this is the genital organ anatomy, uterus and ovaries. So by doing this, this was standard AIUM guidelines, and we used to finish the pelvic organ scan. Hence, we could identify any chocolate cyst, and there ended the scan. But what else can you make out on the same pelvic ultrasound by using strategies? Now you place the probe on the perineum and look at the anterior part. This is the anterior compartment structures. So what are the anterior compartment structures here? It is the bladder, urethra, periurethral regions, then vesico-uterine regions, and distal ends of the ureter. So this is the lap anatomy. If you look beyond the bladder, this is the vesico-uterine pouch. This is the peritoneal reflection on the surface of the bladder, moving on to the uterine body and fundus. So this is a potential recess, and the same anatomy can be seen on laparoscopic images here. And if you move the probe more laterally from the anterior aspect, distal end of the bladder, around 2 to 4 centimeters laterally, you can trace the terminal ends of the ureter coursing from the paracervical regions to its entry into the UV junctions. So this anatomy can be traced on ultrasound. It is only strategizing, utilizing the same machine and having an orientation of the organs and identification of the landmarks. So coming to the posterior compartment on transperineal views, if you look at the normal anatomy, here, this is the pictorial representation. This is the perineal body. This is the rectovaginal septum, extraperitoneal part, intraperitoneal part, anal canal, rectal ampulla, external and internal sphincters, and puborectalis. So this is the perineum, probe on the perineum, perineal body, rectovaginal septum, extraperitoneal part, anal canal. This is the anterior and posterior parts of external anal sphincter. This is the anal canal, and then this is the rectal ampulla. So if you move the probe in the posterior manner, this anatomy can be seen. So you see, this is the rectovaginal septum, rectum. This is the posterior vaginal fornix and pouch of Douglas. So you can see beautifully the echogenic lining of the peritoneum draping the surfaces. So the same anatomy you see on lap, it is seen as stripe of connective tissues, which is composed of this posterior parametrium is seen as stripe of connective tissues composed of collagen fibers, nerve vessels, and extracellular matrix, which is oriented in horizontal direction. So this, for identification of this anatomy, we should be used to identify the landmarks. Like here, what is the landmark corresponding to this anatomy is the cervix. So if you place the probe on the cervix, you look at the extraperitoneal portion of the rectovaginal septum. This is the anal canal. This is the pouch of Douglas reflection. And this is the intraperitoneal portion of the rectovaginal septum. So the same anatomy is seen on laparoscopy. So what forms the landmark? Once you place the probe at the level of external os on an axial section, the echogenic lining, what you see here is the rectovaginal septum. And if you move your probe more cranially at the level of paracervical region where the uterine arteries enter, that is the level of attachment of uterosacral ligaments. So uterosacral ligaments per se are not identified on ultrasound. As you see here, there are stripes of connective tissue, but the landmark here is the internal os of the cervix. So at the level of internal os of the cervix, the posterior stripe is the level of uterosacral ligament. Now coming to the lateral parametrium. Lateral parametrium is paracervical. It is divided into medial, lateral and far lateral compartments. So if you look here, this is the cervix. We are orienting in an axial manner from caudal to cranial. So this is the level of the parametrium where the uterine cells enter through the parametrium. So this portion where you're seeing the echogenic specks, this portion is the vaginal fornix, extraperitoneal portion. Now, once you move up above, this level is the left side of expected uterosacral ligament attachment. And this is the parametrium, which is divided into medial and lateral by the course of the ureter. So this lateral parametrium is best assessed on MRI because the important structures, the nerves form the component of the lateral compartment. So the most important nerves which run in this lateral compartment are the sacral plexus nerves, sciatic, pudendal and gluteal, and this uterosacral ligaments through which the inferior hypogastric nerves run. So these are the landmarks for identification because deep infiltrative endometriotic lesions involve these areas. So lateral parametrium is better assessed on MRI. The levels of involvement can be medial to the ureter, between the ureter and the hypogastric nerve, and lateral to the hypogastric nerve or inferior gluteal vessels, and lateral to the greater sciatic foramen. Now once you're done with the genital organ anatomy, the peritoneal reflections, anterior and posterior compartment anatomy in a craniocaudal manner, you look at the suspensory ligaments of the female genital organs. They are uterosacral ligaments, cardinal ligaments, broad ligament, round ligament, and suspensory ligament of the ovary. Now, if you see here, the ligaments are nothing but connective tissue structures through which the important structures run through. So, round ligament is seen along the anterior aspect. Uterosacral ligament is seen from the cervix coursing down to the ischial spine posteriorly. So how are you going to identify the uterosacral ligament? It is attached proximally by torus utrinus to the lateral aspect of the cervix and the upper part of the vagina and distally to the coccygeus muscle. So this is the uterosacral ligament on a sagittal MRI. So if you look here, this ligamentous structure is difficult to identify, but the landmark is the internal os of the cervix. The uterosacral ligaments located lateral to the rectum and medial to the, so the uterosacral ligaments are lateral to the rectum. They form the margin of the mesorectal fascia and they're medial to the ureter, provide the boundaries of rectouterine and rectovaginal spaces. Why it is important? Because of involvement of DIE nodules of uterosacral ligaments. You identify the chocolate cyst part of it very easily, but you miss this uterosacral nodule sitting right beneath this. Coming to cardinal ligaments form the base of the broad ligament and it contains the vessel. It is oriented in a coronal manner from lateral to medial. It contains the internal iliac arteries, uterine artery and vein, vaginal and vesical arteries, and nerve fibers. Ureter course under the cardinal ligament. So this is the cardinal ligament anatomy. as seen on a schematic representation. But this anatomy is difficult to identify on a conventional imaging sequence. You only identify this as vessels coursing from the internal iliac arteries in a longitudinal manner to mediolateral fashion into the cervical region. So this connective tissue region containing these vessels form the anatomic boundary of cardinal ligament attachment. So similarly, broad ligament. Broad ligament encompasses the fallopian tubes with their blood vessels, the round ligament, uterine, and some ovarian blood vessels. So broad ligament is a drape of double fold peritoneal tissue. So identifying the landmarks is cornual ends of the uterine fold. So broad ligament attachment expected is this. It's a fold of the peritoneum and you have to trace the uterine tube along the lateral aspect. Round ligament is covered proximally by the broad ligament and it courses anteriorly through the inguinal canal and terminates in labia majora. So here you see the axial view images are best because the orientation and anatomical course of round ligament is from posterior to anterior to the inguinal canal. So they're best identified on axial images. So this tissue is the round ligament, which is responsible for the uterine version. See the endometriotic involvement of the round ligament by the ovaries being stuck. So this is all spectrum of DIE. So after the suspensory ligament of the ovary or infundibulopelvic ligament, it's a thin fold of peritoneum along the lateral margin of the ovary to lateral pelvic wall. It contains ovarian artery, ovarian nerve plexus, and lymphatic vessels. It is best identified on axial view. So if you see the ovarian ligament schematically, it is along the lateral pelvic wall, see, as seen on lab. So separately in an anatomy, you will not see it, but it is seen on axial, best identified on axial images as a narrow soft tissue band extending from the ovary along the direction of external common iliac vessels. Why this is important is in difficult organ of origin situations, like whether it is an pedunculated subserous fibroid or an ovarian mass, the vessels draining into it, organ of origin identification landmark this forms. So identification of this anatomical landmark is important. So after the suspensory ligaments of the genital organs, we go to compartmental anatomy of the female pelvis and pelvic spaces. So intraperitoneal and peritoneal demarcation can be made. The intraperitoneal aspect of it is uterine corpus, the adnexa, the small intestine, sigmoid colon, and upper rectum. The extraperitoneal anatomy comprises of the pelvic spaces, which are prevesical space, vesicocervical, vesicovaginal, rectovaginal, and the presacral and retrorectal space. The urinary bladder, cervix, vagina, lower part of the rectum are also located extraperitoneally. Now you can see this anatomical representation. All this organ boundary as seen by the yellow line is intraperitoneal, and the ones beneath this reflection is extraperitoneal. So the urinary bladder, cervix, vagina, lower part of the rectum are extraperitoneal, and all the pelvic spaces like prevesical space, vesicocervical, vesicovaginal, rectovaginal space, these are presacral and retrorectal space. These are all extraperitoneal pelvic spaces. So once we are done with the understanding of the anatomy, so when you are doing the scan live on the patient, you need to have the checklist when you are evaluating the female pelvis. So the first thing, as we are used to doing, that is female genital organs. Then you move over to identify the ligaments of female genital organs, then compartmental anatomy of female pelvis and spaces. So with this anatomy in mind, now I think you will be more convinced to accept that the traditional teaching of surgery or histology is the best, or clinical diagnosis is best, is moved to the with improvements in imaging with dedicated protocols and standardized structured reporting. Ultrasound is best with definite role of MRI. So there is definite shift, But this requires an understanding and moving away from the routine, strategizing our scan methodology. Now, coming to imaging in endometriosis. What are the roles of imaging in endometriosis? From a diagnostic perspective, it provides diagnosis for subset of people, assess the severity of pelvic endometriosis, visualize the anatomical areas not visible surgically, and it avoids invasive surgical for diagnosis, minimize risks associated with diagnosis, affordable, available, and acceptable and safe. With respect to preoperative role of imaging, it provides information to the surgeon with disease mapping. Thereby, he can arrange techniques and protocol. In imaging, the level of expertise plays a fundamental role in diagnostic performance. As is known, what the mind does not know, the eye cannot see, even if it exists. In this regard, it is prudent to say that the spectrum of deep endometriosis existed far before its detection on imaging in recent years. So, for every learning curve, I think clinical interaction with retrospective viewing of images and better understanding of the disease process and pelvic anatomy allowed optimization of the imaging techniques and development of dedicated meticulous protocols on imaging, which guarantees good diagnostic performance in identification and mapping. Now, if you look at the available imaging modalities in clinical practice, ultrasound and MRI, having a comparative knowledge about this is important because for choosing and triaging the patient, it will be helpful. The advantages of ultrasound is proven and established. It is dynamic and interactive. This is the most important advantage of the ultrasound, which cannot be taken away. It is non-invasive, commonly available and affordable, minimal risk and discomfort, and the disadvantages being inherent to the modality, shadowing, significant pelvic anatomy distortion, limited field of view, and beyond the machine, it is operator dependent, knowledge of the disease and techniques employed. When you come for MRI, the most important advantage of MRI is large field of view, direct multi-planar images, enabling simultaneous evaluation of all the compartments with excellent soft tissue characterization, providing high accuracy and specificity, delineating the pitfalls, thereby forming an apt complementary modality to ultrasound. Disadvantages to MRI exists, and they are patient's anatomical factors, suboptimal images due to bowel peristalsis, fecal residue, redundant sigmoid colon, and extensive pelvic anatomy distortion, precluding individual detailing. So ideal would be to exploit the advantages of both. Comprehensive integrated imaging modality is the demand of the day and should be practiced whenever available and feasible. So the protocol which we follow is pre-exam standard protocol, bowel preparation using Dulcolax tablet or Dufelax syrup 30 ml night before, a low residue diet. For MRI, IV Buscopan to reduce bowel movements and uterine contraction is administered immediately before the examination. And for better evaluation of the rectovaginal septum and vaginal vault, 60 ml of intravaginal ultrasound gel is applied. And what is the dedicated endometriotic ultrasound protocol for evaluating pelvic ultrasound? Is before the ultrasound, a good clinical assessment, specific pain sites, guiding the examination to pain-specific areas will increase the diagnostic yield. This is extremely important and I cannot emphasize it more. So before the ultrasound, you really need to have a very good clinical assessment, which is directly proportional to the diagnostic yield. Second, with this clinical assessment, the standard ultrasound protocol will include standard ultrasound transabdominal or transvaginal as described by AIUM guidelines. This is to look at the uterus for size, shape, orientation, periuterine planes, endometrium, myometrium, cervix, the adnexa, the cul-de-sac, as we do in routine. So this is step 1. So this is genital organ anatomy standardized imaging. In addition, we also need to look at the compartmental anatomy. So start with the anterior compartment structure, bladder and vesicouterine pouch, pouch of Douglas posteriorly, the vagina, rectovaginal septum, bowel, rectum, and rectosigmoid, for which targeted compartmental evaluation is described. Evaluating anterior, middle, and posterior compartments. So this constitutes step 2 and 4 of evaluation. So step 2 is evaluation of sonographic soft markers, that is site-specific tenderness and ovarian mobility, dynamic assessment of posterior pouch of Douglas and anterior vesicouterine pouch using real-time ultrasound-based sliding sign. And step 4 is assessment of deep endometriotic nodule in anterior and posterior compartment. Then optional is tenderness guided site-specific sonography. So if you look here, the practical implication or part of it. So this is a known case of endometriosis with Mirena coil in situ on Dynogest. Post-op status for adenomyosis and endometriosis. Follow-up assessment, previous imaging findings dated 8/9/21 was compared. And if you look here into this imaging, so this is the uterus. So it is showing heterogeneous echo pattern with multiple scattered myomas of varying sizes occupying anterior fundus and posterior wall. The endometrial cavity reveals Mirena coil in situ, the loop. And this is the transverse plane. We are going from caudal to cranial. This is the lateral parametrium. Okay, so this is the vaginal fornix level of parametrium. This is the extraperitoneal portion of the rectovaginal septum. You move more cranially to the part of the uterosacral ligament attachment site. Okay. So once we are done with this, this is anterior compartment. You are moving your probe anteriorly. This is the terminal ureter tracing. See, this is the terminal ureter coursing from the lateral aspect to enter into the bladder here. And then see, if you finish the scan at this without following the IDEA consensus, we would finish with uterus, fibroids, adenomyosis, ovaries, and then finish the scan. But here, if you look at the frame, I am moving from anterior to posterior part. This is the ovary. This lesion is the one which I want you all to look. So this is the posterior compartment assessment. You are tracing the bowel, anal canal, rectal ampulla. This is the intraperitoneal portion of the rectovaginal septum, anterior wall of the rectum. See, the anterior wall of the rectum is thin. The muscular layer is not more than 3 millimeter in a well-prepared bowel. And what we see here, this thin rectal wall is leading to a curvilinear, deeply hypoechoic deposit flushed with the anterior wall. So this is the rectal nodule. So she is managed for endometriosis, but this rectal nodule is the one which was troubling her. So this is the rectal nodule. It is seen as a deeply hypoechoic solid nodule projecting into the adjacent rectovaginal space. So here the anatomy is extremely important. Once you identify the anatomy, you will pick up the abnormality and characterize it. The crux is revisiting the anatomy. So here, finally, the impression would be multiple varying size fibroids. The ovaries are unremarkable for chocolate cysts. The inflammatory distribution of deep endometriotic lesion is seen as a bowel nodule, which is eccentric, covering so sagittal and axial views. You see the bowel lesion is eccentric, projecting into the rectovaginal septum, covering approximately or less than 40% of the bowel circumference. And this bowel is adherent to the right ovary and right parametrium. So here another case, this was a 37-year-old female, history of laparotomy for left ovarian cyst in 2009, and 9 underwent laparoscopic laparotomy hysterectomy with bilateral salpingo oophorectomy for endometriosis. Surgical findings reported dense adhesions. So the present clinical complaints in 2021, 2 years after the surgery, heaviness on right side of the lower abdomen, which is non-specific. So the ultrasounds were done. Prior ultrasound images for evaluation of the same complaints revealed thick-walled, multiseptated cystic lesion in right hemipelvis at the expected location of right ovary, showing internal low-level echos. This was the report which she carried when she came for the scan, suggesting the possibility of residual right ovary with right ovarian endometrioma. So the present indication was second opinion scanning for confirmation of the same. So here we see, so this is the probe. So this is the vault post hysterectomy status. What we see here, I think by now you will appreciate, this is the bowel wall leading to irregular hypoechoic nodule projecting into the rectovaginal space. This is deep endometriotic nodule of the bowel. So this was interpreted against the backdrop of fluid-filled bowel loop. It was interpreted as multiseptated cystic lesion in the right hemipelvis. So the lesions or the images never lie. It is only the interpretation. So for this interpretation, if you look, it is the strategy, anatomy remaining the same, understanding the anatomy with respect to its compartment, and then making sense of the overall picture, led us to diagnose this as a bowel nodule. She was put on Dynogest and she was symptom-free and absolutely happy. So if you look for transabdominal protocol, so transabdominal protocol, as we have seen, the compartmental anatomy extrapolation can be done. So this is the bladder. We are starting from the inferiormost aspect, bladder, vagina, and posteriorly anal canal. I am moving up. So these are the terminal ends of the ureter, UV junction. I am moving more cranially. So this is the cervix, paracervical region. This is the uterus. And what we see here, this is the right ovary. Yeah. This is the vagina, cervix, myometrium, endometrium, anterior compartment structure. This echogenic line is the vesico-uterine fold of the peritoneum, coursing posteriorly from the fundus posteriorly. See, this is the posterior reflection of the peritoneum. This is the pouch of Douglas. So this is the posterior anorectum. This is the cervix. So here the anteverted uterus and retroflexed, mildly retroflexed fundus, fluid outlining the pouch of Douglas, and this is the bowel. So this bowel is grossly unremarkable to the extent seen, and the right ovary is seen lateral to the, it is seen lateral to the posterior aspect of the uterus in the expected location of the broad ligament reflection. So coming to MRI, the MRI pulse sequences in pelvic endometriosis evaluation the hemorrhagic nature of the lesion is essential element in their characterization, because we understand the endometriotic lesions are chronic recurrent bleeds. So the strength of the MRI is excellent soft tissue characterization and signal characterization to pick up the hemorrhagic nature of the lesions, adding specificity to the diagnosis. So three-plane anatomy, large FOV provides us a good pelvic view anatomy. Here, as we see, the distorted pelvic anatomy beyond the genital organ. This is the anterior vesicouterine space, the peritoneal reflection. The posterior contour is, hello?
हाँ madam.
Is it now seen?
Yeah, it is visible.
Okay. So here, if you look at interpretation grossly from out to in, so look at a larger picture. This is the three-plane anatomy of the pelvis. Now zoomed out to the anatomy. Transcompartmental, anterior, middle, and posterior. So anterior compartment structure, bladder, urethra, extraperitoneal spaces, as we have seen. This anterior vesicouterine space, this thin line of peritoneal reflection, the clarity here is completely obliterated along the posterior reflection. So this is a telltale sign or a direct evidence of peritoneal involvement. So you shouldn't stop at identifying these ovarian lesions, but you have to go beyond the typical genital organ anatomy to evaluate the suspensory ligaments, compartmental anatomy, spaces, thereby providing the roadmap. So here, if you look, there are cysts in the adnexa, two cysts. One is showing feature of chocolate cyst, other is showing features of functional cyst with intracystic hemorrhage, showing typical fluid clot level. If you look at these axial images, as we have seen the clarity of the imaging at the expected level of the uterosacral ligament, this is completely distorted, and deep endometriotic nodules are on imaging appearance separate or distinctly different from the typical endometrioma. They are solid lesions with irregular margins and show foci of ectopic endometrial glands or hemorrhage. So this is the coronal plane. So this is a transcompartmental view which will be useful for overall writing the report, providing roadmap to the surgeons in complex or multi-compartmental involvement. So the role of MRI is undoubtedly there, and it is better you understand and embrace modality. So what are the pulse sequences in pelvic endometriosis evaluation and assessment? It is workhorse is T1 weighted and T1 fat sat, because as we understand, picking up hemorrhagic nature is the crux. So blood appears bright on T1 weighted sequence, which persists on T1 fat saturated, because T1 hypersignal has multiple other causes like fat, proteins, but it will not be suppressed on fat saturated sequences. So T1 and T1 fat sequences are crux for pelvic endometrioma diagnosis. Apart from that, diffusion with ADC are optional sequences. They are useful for deep endometriotic lesions because they have ectopic endometrial tissue like signal with low, they parallel the endometrial tissue signal. So diffusion with is in identifying endometriotic susceptibility weighted imaging, which blooms up the hemorrhagic residual products. So this is a sequence which we have extrapolated from brain imaging. So this highlights the hemorrhagic products beautifully. So if you see here, not only the conventional sequence chocolate cyst, here you can see multiple areas of blooming over this anatomical area. If I have to characterize, I will say this is the peritoneal reflection of the uterus. Anteriorly, this is the vesicouterine space, and this is the ovarian reflection along the broad ligament, and posteriorly, this is posterior broad ligament or torus utrinus. So apart from the chocolate cyst and ligaments, it can characterize multiple areas of blooming over the peritoneal reflection, providing a role or diagnostic yield for superficial peritoneal endometriosis, which up till now was not diagnosed on ultrasound or conventional MRI. If you want to understand the importance of this, let us look at this ultrasound imaging. This is a Miss patient, 25-year-old with severe dysmenorrhea. So transabdominal ultrasound, as we see here, the vesicouterine space, anterior fold of peritoneum is very clear. The uterus is grossly unremarkable. Posteriorly, the retrocervical area is also unremarkable. The endometrial cavity is midline. Both the ovaries are normal. We could only see a right lateral intramural mass abutting the endometrial outline infracornually, and ovaries were normal. With this report, we could not explain her dysmenorrhea. So this pain was lower abdominal, predominantly during periods, more on right side radiating to leg. This was the complaint, and this was the set of images. So the second thought came whether this could be an ACM or a variant of adenomyoma, which could explain the pain. So we asked for an MRI during post-menstrual phase to assess the significance for ACM, accessory cavitating uterine mass, to pick up blood degradation products within. And these are the MRI images. Now you see the uterus is retroverted, very clean, grossly unremarkable. But only when you look at the uterine tracing, the cervix and the uterine body, the retrocervical region is blunted here with a tiny hypointense area. And the so-called right myometrial mass was myoma, and no blood degradation product was seen. Both the ovaries were unremarkable. But see the value of SWI sequences, it picked up tiny foci of blooming on the ovarian surface, which were not imaged or evident on conventional sequences. And if you look at that area of retrocervical region, which corresponds to the uterosacral ligament, the right uterosacral ligament shows significant blooming. So the final contribution of MRI in this case was the myometrial SOL did not reveal internal cystic area consistent with ACM. However, dedicated SWI sequences picked up blood degradation products with blooming consistent with peritoneal endometriosis in the following locations: posterior-inferior aspect of the uterine body at the level of torus uterinus, this area at the level of torus uterinus, the right uterosacral ligament, ovarian peritoneal reflection, and 8 to 10 mm foci of blooming in right ovary. This patient underwent laparoscopy and was confirmed on laparoscopy to be peritoneal endometriosis. So here, absolutely the strategic involvement of the imaging modalities with a very keen introspection of the patient's clinical symptomatology will lead you to pick up this diagnosis. Otherwise, the imaging is grossly normal, but her clinical symptoms were shouting: right-sided lower abdominal pain radiating to right leg. And she has been suffering this for over 10 months. So to finally conclude here, mid-position uterus, retroflexed mid-body and fundus, the focal myometrial lesion of 35 millimeter in the right anterior uterine body shows features of intramural myoma and not ACM. Additional SWI sequences with relook subtle findings suggestive of peritoneal endometriosis noted in right adnexa along the uterine peritoneal reflection, torus uterinus, right uterosacral, and ovarian peritoneal reflection, with subtle definite adhesions between right ovary, right uterosacral ligament. No chocolate cysts were identified. So this could explain her clinical symptoms, and that was lab confirmed. Now, this is how we do in practice. Now, after doing ultrasound or MRI reporting using ISGE recommended documentation system, that is NZM classification. So NZM classification is nothing but providing a common uniform language of the disease across the anatomy amongst the clinicians or the management guided people, like among the radiologist, among the surgeon. So you look at the pelvis as a whole, frozen pelvis or pan-compartmental involvement with obliterated plane. Then you zoom in into compartments: anterior compartment, mid compartment, posterior compartment. In anterior compartment structure, bladder and ureters. Middle compartment, it is again the organs, uterus, signs of adenomyosis or foam, ovaries, lesions compatible with endometriomas, tubes, peritoneal pseudocysts. So each is given a label. Posterior compartment, it is caudocranial involvement, caudally to cranially, caudal-most rectovaginal space, then you go up to vaginal fornix, then you go to the retrocervical space. This is caudocranial. Then NZN B is mediolateral. Mediolateral is uterosacral ligaments, cardinal ligaments, and pelvic side wall. Then rectum, then pouch of Douglas. So I hope you understand this NZN classification but once you understand the compartmental anatomy and the patterns of involvement, NZN classification is nothing but standardized reporting of the involvement across the compartment. That's it. So summary of the report is given as code. This is peritoneal involvement. O is ovarian involvement. T, tube or tubal lesions. P, O, T, A, B, C, F. P is peritoneum. O is ovary. T is tube. A is caudocranial involvement with respect to rectovaginal septum, vaginal fornix, and retrocervical region. B is mediolateral with respect to uterosacral ligaments, cardinal ligaments, and lateral pelvic side wall. C is involvement of rectum. F is faraway location with respect to bladder, intestines, ureter, and other lesions. So we have done a study of preoperative mapping and structured reporting of this pelvic endometriotic lesions on dynamic ultrasound and its correlation on lab using NZN classification, which had a high degree of correlation. So our clinical experience pointers are: the anatomical distribution of the lesions determines the clinical manifestations. So this clinical assessment is extremely important for us to identify and triage the anatomical targeting by improving the diagnostic yield. Pelvic endometriosis involves multiple compartments simultaneously with predominant involvement of posterior compartment structures in deep endometriosis, namely the uterosacral ligaments, rectovaginal septum, anterior rectal wall, and sigmoid colon. The frequency of endometriotic implants in each of these compartment locations, clinical features with corresponding pool sensitivity and specificity of detection is listed here. If you look at our experience, the compartmental prevalence is predominantly posterior, followed by middle, followed by anterior. And the clinical symptomatology is distinctly different across the compartment. So clinical evaluation is extremely imperative. And if you look at the sensitivity and specificity, ultrasound and MRI are almost similar. So ultrasound can be utilized as primary diagnostic tool. And if you look at the edge over of MRI, it is the lateral compartment involvement. Parametrial involvement is better assessed on MRI. Now, once you look at the endometriosis, identification of endometriosis, spectrum of endometriosis, and then reporting the endometriosis. So if you look at the patient from an imagiologist point of view, not all cases of pelvic pain referred with the suspicion of endometriosis turn out to be endometriosis. Now, if you look at the diagnostic criteria, checklist of endometriosis on ultrasound and MRI, you should understand also the potential mimickers, pearls to identify these lesions, pitfalls and variants, and sequelae. So diagnostic criteria for endometrioma, you follow IOTA terminology, unilateral, bilateral, multilocular or unilocular avascular cyst with ground glass appearance and peripheral echogenic foci. MRI, T1 fat sat bright with T2 shading, diffusion weighted not specific. SWI images show foci of blooming at the periphery. They all aim at identifying blood degradation products. Deep endometriosis, they are distinctly different in imaging appearance to endometriomas. They are solid, poorly defined margins, hypoechoic on ultrasound, and predominantly T2 hypointense, which is a sign of benignity, with infiltrating retractile regions or margins. They are all low signal on T2 weighted with occasional high intensity foci on T1 weighted. Foci of ectopic endometrium show restricted diffusion. For diagnostic checklist, we have already seen this mandatory to be included in our reporting assessment. The potential mimickers of endometrioma, trickiest mimickers are hemorrhagic cyst, cystic neoplasm, dermoid, PID. The pearls or the distinguishing points to be picked up is T1 and T1 fat sat bright signal, T2 shading or T2 dark spot is a characteristic sign of endometrioma, hematosalpinx, foci of restricted diffusion representing ectopic endometrium in scar endometriomas and atypical locations. Now you saw the mimickers pearls. Because we understand the endometriosis is a recurrent inflammatory condition, so it will have sequelae. The range of sequelae can be with respect to distorted pelvic anatomy. So understanding normal is imperative in identifying the abnormality. So abnormalities can be in the form of kissing ovaries, obliteration of pouch of Douglas or vesico-uterine space, varying degrees of adhesions, ureteric involvement, hydrosalpinges. So endometriosis complications or pitfalls are rupture, infection, malignant transformation, intraluminal invasion, rectal or bladder, complete bowel obstruction. So they might present to you with a surgical emergency also. Missing subtle disease, undercalling multi-compartmental involvement with frozen pelvis, and decidualized endometriomas. So these are the challenging areas within pelvic endometriosis encountered in clinical practice. Coming to variants, you can have abdominal wall endometriosis, perineal endometriosis, ureteral endometriosis, invasive endometriosis of posterior uterine wall or anterior uterine wall, that is foam, appendiceal, diaphragmatic. So again, all these variants are determined by the clinical symptomatology. So typical appearance of endometrioma, ground glass, unilocular, multilocular, thick-walled cyst with peripheral echogenic foci, vascularity around the wall, not intraluminally. So this is characteristic. Around 95% of the times we are very confident in identifying endometriomas, but definitely there exist trickiest mimickers. And what are they? Most common is the hemorrhagic cyst, which is mimicked with an endometrioma. But as we see, the important distinction between the hemorrhagic cyst and an endometrioma is hemorrhagic cyst is a one-time event. So it has to evolve and resolve. Whereas endometrioma is a chronic recurrent bleed. So logically speaking, this will have varying appearance across time frame, resulting in invariable resolution. So initially it might appear as solid, but then fishnet appearance, retractile clot with concave margins, decrease in size, involution. This is the natural timeline of a hemorrhagic cyst. But sometimes, and most important, clinical history, day of the cycle. Again, you look at the margins, periovarian planes are relatively spared. There is no other feature of endometriosis elsewhere. So, but sometimes we come across patients with MRI referral suspecting chocolate cyst or confused with hemorrhagic cyst. Here, this is a classic example. What we see here, this is a chocolate cyst and this is a functional cyst with intracystic hemorrhage. So as we saw, T2 weighted imaging, characteristic of endometrioma is shading. Shading is nothing but varying degrees of decreased signal intensity on T2 weighted images when compared with physiological fluid. Most easy here is urine. So endometriomas have varying degrees of decreased T2 signal intensity on MRI from minimal to urine to as dark as bowel or bone. So only if you rely on T2 weighted sequence, you might miss an endometrioma which has a dark T2 signal similar to that of a bowel content. Okay, so that is T2 shading. The second cyst here is the signal, the fluid signal, there is a leveling, dark dependent and a fluid signal. This fluid is similar to that of urine. And if you look at multi-sequence images, The one on the top, which is showing T2 shading, is appearing T1 bright, persisting bright on T1 fat sat. Whereas this inferior cyst, it is showing fluid signal, hypointense on T1 with leveling isointense clot on T1 fat sat. So this is hemorrhagic cyst and this is endometrioma. So it can be a mimicker, trickiest mimicker on ultrasound. So next here comes, this is an axial T2 weighted section of the pelvis. And here we see a thick walled unilocular cyst occupying the vesicouterine space. The right ovary is seen. So incidentally detected ovarian cyst. This patient did not have any complaint of dysmenorrhea. So the provisional diagnosis of cystadenoma was made and referred for an MRI. So to our surprise, what we saw here, it is a unilocular cyst, but it is lighting up like bulb on T1 fat sat images, and SWI images shows peripheral areas of blooming. So cystadenomas can be a mimicker of unilocular dermoid cyst. So here the T2 shading with T1 fat sat signal adds specificity to the diagnosis. So the role of MRI is undisputed in pelvic endometriosis. Now the third case scenario, this is a right adnexal cyst. Left ovary looks normal, and here it was interpreted, here this is T2 almost bright, T1 bright, T1 fat sat bright. Look at the series of images below. This is also T2, this is T1, this is T1 fat sat. Here also the cyst is showing evidence of T2 shading and varying degrees of T2 brightness. On T1, this locule is bright, but on fat sat images, it is completely suppressed, consistent with fat and not blood. So another mimicker here is dermoid cyst. Sometimes dermoid cysts can be mimicked for an endometrioma. And the fourth case scenario here, this is top row images. I think by now you might have got accustomed of identifying an endometrioma. T2 shading, T1 bright, T1 fat sat bright. Now compare this with lower row of images. Here also it is T2 shading, decreased range of T2 signal, and it was given as endometrioma, pelvic endometriosis, and sent for examination. But here you see signal characterization wise, this ovary cyst is showing T1 iso to hypointense signal on T1 and not bright on T1 fat sat. So it is not endometrioma. Now you zoom out and look at the pelvis as a whole. If you see the fat along the compartmental anatomy, it is all dirty. There is increased vascularity. There is ill-defined planes across the pelvic compartments. So these are all features of pelvic inflammation. This is PID with TO abscess. So TO abscess also mimics endometrioma on imaging appearance. So now we have seen the trickiest mimickers of endometrioma being hemorrhagic cyst, dermoid cyst, cystadenoma, and PID. Now, fallopian tube involvement. 30% of women with endometriosis have tubal involvement. Tubal involvement can be either direct endometriotic deposits on the fallopian tube, or most commonly it is obstruction secondary to external adhesions on the pelvic peritoneum. So this is a typical hydrosalpinx, sausage-shaped, incomplete internal septations. Undoubtedly diagnosed, you cannot miss a hydrosalpinx. On multiplanar images, you see the sausage-shaped structure with different degrees of T2 shading with the endometrioma at the base. Coming to the second spectrum of pelvic endometriosis, that is superficial peritoneal implants. Current limitation of imaging to pick up early peritoneal endometriosis. The peritoneum defined relative to peritoneal surfaces which are normally clear, sharp, smooth margins. On imaging, we do not identify peritoneum. We interpret peritoneal surfaces as clear, sharp, smooth margins between the organs. Here, The role of SWI sequences of MRI exists, as we have seen in previous cases. Foci of blooming along the peritoneal reflections. Subtle but definite features of ultrasound are subtle peritoneal thickening with ill definition, cystic areas that come out of the peritoneum, pockets of fluid, filmy irregular adhesions. So here you look at this case, 28-year-old female with severe dysmenorrhea, ultrasound pelvic organs ordered. So this is ultrasound pelvis. So this is uterus. Now can you see, if I ask you to trace the peritoneal lining of the uterus, I think every one of you will understand the beauty of the lack of clear, sharp margins along the uterine peritoneal reflection along the posterior aspect. See, this is the anterior peritoneal reflection. As we go behind, this peritoneal reflection is thickened and I'm not able to outline this peritoneum clearly. And the right ovary is stuck. So if you look at MR, here the uterus is retroflexed and there are tiny chocolate cysts, and SWI sequences reveal significant foci of blooming along the uterine peritoneal reflection with bowel loops adherent to the uterine body posteriorly. So this range of findings, for us to understand, you have to have an idea about the clinical picture that will guide you. Dynamic scanning was tender and restricted, and the ultrasound revealed only subtle hypoechoic nodules along the torus uterinus and posterior inferior aspect of the uterine body. See, this is the ultrasound picture. So this subtlety is the ultrasound image, which could be confirmed on MRI. And these are the susceptibility weighted sequence images, which reveal multiple foci of blooming across the peritoneal surface reflection. You see here. So here, this is another case. Subtle peritoneal endometriosis and ultrasound for MRI confirmation, cyclical aggravated pain during periods. So here, this was the picture, cyclical severe dysmenorrhea aggravated during the periods. Now here you see the range of imaging appearance. Here it is not traditional chocolate cyst or a large bowel nodule, but only these multiple blooming predominantly distributed in the right adnexa and posterior compartment. Now you correlate with her clinical complaints, this explains. So you identify endometriosis, you give the inflammatory lesion distribution on anatomy. Coming to the third part of the pelvic endometriosis spectrum, that is deep endometriosis. Why is it important to recognize? So as we saw, endometriomas are easily, readily recognized, but it also forms a soft marker for underlying deep infiltrative endometriosis because endometriomas are easier part of the surgery and deep endometriosis goes unrecognized, which is the complicated part of the surgery. As we have seen, the role of imaging in the diagnostic part, management part, the role of imaging is to provide a roadmap to the surgeon to assess the severity, to map the compartment, because it will aid in getting an informed consent from the patient, arranging the team, estimated resource involvement, and all those things. So for that reason, if you don't recognize DE, so that part of the surgery, the complicated part of the surgery, you are not going to help the clinicians. So deep infiltrative endometriosis is defined as the solid endometriotic implant more than 5 mm deep to peritoneum as seen on lap. These have classic locations of involvement in pelvis, most commonly epicentered in pouch of Douglas. The second thing is, why is it difficult to recognize? So these anatomical locations are difficult for direct visualization. As we have seen in the anatomy revisit, those reflections, compartmental spaces, and those anatomical landmarks are difficult for direct visualization, and you need various landmarks corresponding to those attachments or folds of peritoneal reflections for its identification. Hence, the imaging pattern is atypical with respect to morphology, as seen as nodular and infiltrative pattern of appearance, with involvement of organs in these regions as ligamentous attachments. Infiltrative regions of deep infiltrative endometriosis may have internal heterogeneous foci or complex internal cysts. Now we have seen why is it important to recognize and why it is difficult to recognize. And we have seen how it can be recognized and what are the strategies. So if you look at the posterior compartment involvement of deep endometriosis, most frequently involved compartment is posterior compartment up to 90%, with the following regions identified on imaging in decreasing order: uterosacral ligaments and torus utrinus, rectum and rectosigmoid, rectovaginal septum, and pouch of Douglas obliteration. So here you see the uterosacral ligaments are the connective tissue structures without a definite anatomical appearance. So here we see the landmark as internal os. So indirect sign is retroflexed question mark shaped or sickle shaped endometrial cavity. The uterus is pulled back. So this is the level of internal os of uterus. This is the torus utrinus. So this is the expected location of uterosacral attachment in the parasagittal sections. So here a deeper involvement sees the distorted anatomy of the uterosacral ligament, which forms the boundary of the mesorectal space. So solid invasive of the rectosigmoid colon. So we have seen the posterior compartment anatomy. This is the extravaginal part. This is the bowel wall. Definite signature of the bowel wall. You trace the rectum. This is the extraperitoneal part of the rectovaginal septum. This is the pouch of Douglas reflection. This is the rectum. And then this is how you see and schematic representation of a normal bowel wall as opposed to the involved bowel wall. And this is how we see on a laparoscopy. Coming to rectovaginal septum and vaginal nodule, we have identified how to see a rectovaginal septum on a normal anatomy and how does a deep infiltrative nodule of the endometriosis seen. So you see the vaginal reflection as a thin muscular layer. It is leading to solid hypoechoic nodule with infiltrative retractile margins, which is tender on palpation. So site-specific tenderness aids in the diagnosis. Here you see, for comparison, this is the vaginal fornix anteriorly, smooth, clear wall with both extraperitoneal portion, intraperitoneal aspect, clear, sharp margin, as opposed to a tender vaginal nodule, which is asymmetrically thickened. So anatomy will be there. It is only our eye to pick up those lesions. So we have seen here time and again, I'll say clinical suspicion, a good clinical assessment will aid in identifying and strategizing the imaging modality. Coming to the rectovaginal septal involvement, this is the hypoechoic thickened rectovaginal space, completely tethering the uterine posterior wall and the rectum anteriorly. And the range of pouch of Douglas obliterations from torus utrinus to as high as upper POD. This is the middle POD, and this is complete pouch of Douglas obliteration. In all these findings, you see deep endometriotic involvement of the posterior compartment. The telltale sign or the striking sign, what you see here is the altered uterine version with retroflexed fundus or sickle-shaped endometrial cavity with fundus facing posteriorly. And the moment you turn the peritoneal reflection posteriorly, it is irregular and thickened. The same can be extrapolated on MRI and the same picture on lab. So here, anterior compartment, detection of endometriosis involving the anterior location is challenging. To meet the diagnostic criteria of DE lesion, the muscularis of the bladder must be affected. The same protocol of the anatomy is the same: urethra, bladder, bladder base, parasagittally ureteric involvement. So if you look here, the same anatomical, this is the tender nodule of the bladder abutting the right lateral aspect of the vesico-uterine space with uterus tethered to this. This patient also has chocolate cysts in the posterior compartment, but her primary complaint was pain during micturition. This did not bother her much, as did the pain during urination. And if you utilize the linear probe because of the proximity to the anterior abdominal wall, here you see the uterine body, and here you are seeing the nodule projecting into the vesico-uterine space and into the bladder wall. Lateral parametrial involvement, round ligament involvement is best assessed on axial sections of MRI. As we have seen, the anatomical orientation is best interpreted or identified on MRI for round ligament. Lateral parametrial extension you see as irregular soft tissue involvement along the medial lateral aspect from the medial to lateral across the pelvic side wall. Because of the multifocal nature of the disease, foci of endometriosis are simultaneously observed at different sites. So owing to possibility to perform complete assessment of all pelvic compartments at one time, MRI represents the best imaging technique for preoperative staging of multi-compartmental complex endometriosis. Now you have seen, so direct assessment of indirect signs of adhesions or atypical manifestations, tethering of pelvic structures and loss of corresponding cleavage planes without appreciable nodular lesions, distorted pelvic anatomy, fixed anteverted or retroverted uterus, medialization or posterior retraction of the ovaries, fixation of the ovaries to ipsilateral ovarian fossa, retraction of bowel towards DIE lesions. These are all the terminologies used for reporting. In the end, it depicts the alteration of the normal anatomy. Elevation of the vaginal fornix, absence of sliding sign, loculated fluid collections, hydrosalpinx. So here you see adhesions on ultrasound and MRI. You see uterus is retroflexed with fundus fixed posteriorly. The uterine planes are ill-defined. The pouch of Douglas is obliterated with adhesions extending all up to the fundus. So the same is depicted on MRI. So if you look at the diagnostic performance of TVS and MRI in pelvic deep endometriotic mapping, the MRI and ultrasound were almost similar with respect to positive predictive value and accuracy. Only the lateral compartment involvement was better assessed on MRI in our experience. So if you look at the compartment diagnostic imaging comparison, TVS MRI performed similarly. Coming to special imaging scenarios in pelvic endometriosis, coexistence of fibroids and adenomyosis, focal adenomyosis of outer myometrium or foam, which is a variant of deep endometriosis and mistaken as adenomyosis. I really want to highlight this area because it is poorly understood and mapped. Complex atypical anatomical involvement, Mullerian abnormality, endometriosis in pregnancy. So these are special imaging scenarios. So foam is a focal adenomyosis of outer myometrium. It's a transserosal invading process. Here it is interpreted as adenomyosis. Adenomyosis is also presence of ectopic endometrial glands in the myometrium. But characteristically, if you see at a typical adenomyosis, it is a junctional zone pathology. The pathology invades from inside out with ectopic endometrial gland myometrial hypertrophy in an inside out fashion. Whereas in a foam, there is relative sparing of the junctional zone and it is a transserosal myometrial mass with irregularity of the serosal outline. So this is a phenotypic manifestation of deep endometriosis rather than a typical adenomyosis. Sparing of the junctional zone and outside to in pathology. So the pointers to identify the foam are in the posterior wall, retroflexed question mark sign of the endometrial cavity. Posterior uterine serosal outline will be irregular. The mass will be separate or sparing of the junctional zone will be there. So here DIE mistaken as adenomyosis and foam. Here the utility of MRI, severe dysmenorrhea. Ovaries are grossly unremarkable on the right side. Left side, you see the periovarian planes are ill-defined and there is a transserosal myometrial mass in the left lateral wall, which was interpreted as adenomyosis on ultrasound without features of pelvic endometriosis. But look at the MRI. Here it showed picked up blood products within this myometrial mass flushed with the ovarian adherence. So it is an outside in pathology, a variant of foam rather than typical adenomyosis. Similarly, here you see, this was interpreted as peripheral adenomyosis, but severe pain. If you look at the signal characterization, this is along the uterine serosal reflection in the right cornual region with blood products and blooming. and similar non-contiguous lesion. So this was in continuity in the same patient on the left side and contralateral right side. So this is all a phenotypic representation of deep endometriosis rather than focal myomas or adenomyosis. Complex atypical involvement, TVS was negative and it was interpreted as peritoneal inclusion cyst, but the patient had severe pain in a post-hysterectomy setting. So here you see TVS, vaginal fornix is unremarkable. There is a loculated peritoneal collection draping the confines of the peritoneum. There is a subtle telltale sign of the bowel wall thickening, and this was interpreted as ovary. If you look at the corresponding MR, it had surface endometriomas here. So it is not simple peritoneal inclusion cyst. It is a DIE nodule. Coming to coexistence of Mullerian abnormalities, this was interpreted as a right chocolate cyst, but the role of MRI multiplanar large FOV images here in the plane clearly demonstrates right ovary separate from this cystic lesion and unicornuate uterus. So this is an obstructed rudimentary canalized non-communicating uterine horn with hematometra. So this is the additional value of MRI in characterizing complex anatomy in multiplanar view with signal characterization. Coming to decidualized endometrioma, this is a pregnancy-induced change with varying degrees of solid papillary excrescences showing increased degrees of vascularity throughout the pregnancy. So here, the crux is on MRI, the signal of the echogenic nodule matches that of the trophoblastic tissue on all imaging sequences against the backdrop of chocolate cyst, and follow-up post-pregnancy shows complete resolution. So locations evaluated better on imaging than in lab. Unaccessible on lab, this is the rectovaginal septal nodule, which was not picked up on lab due to dense obliteration of POD due to adhesions. So endometriosis of abdominal wall and pelvic scar. Scar endometriosis may be confined to superficial layers of the abdominal or pelvic wall. Endometriosis of the vault in post-hysterectomy setting at the uterine LSCS scar. So this is the abdominal wall endometriosis, scar endometriosis. Here, as we saw, the role of diffusion weighted imaging in picking up ectopic foci of endometrial tissue. So here the role of diffusion comes to play. And this is vaginal vault endometriosis in the setting of post-hysterectomy. This was interpreted as Nabothian cysts. But here, signal characterization of MRI, this was tender and this was a DIE nodule along the vault. And this patient had severe right-sided lower abdominal pain for unknown reasons, multiple times worked up. So here, this is a uterine scar endometrioma along the right lateral aspect. This is the diffusion weighted sequence. So coming to the spectrum, we have seen the spectrum identification. So what are the surgical implications of these imaging findings? If you look at surgery for endometriosis, you have outcomes and you have risks and complications. So there is a beautiful interbalance between outcome and risk and complication. Preoperative imaging, when done properly with meticulous protocol and dedicated imaging protocols and standardized reporting, after a good clinical assessment, will definitely improve the surgery for endometriosis by improving the outcomes and decreasing the risk and complications. So, at the end, what does the referring physician needs in imaging? Clinical triage by standard clinical assessment is the most important, undisputable role in treatment decision making, as the clinical features depend on the inflammatory distribution of the lesions, which
Recording in progress.
is not feasible, like in setting of unmarried complex obstructive carcinomas, we have seen earlier pitfalls and potential min of endometriosis, for specificity or suboptimal evaluation in difficult anatomy or advanced disease adds to ultrasound prior to surgical management. Is to confirm, as seen, the involvement of uterosacral ligaments, which was differentiated, which could not be picked up on ultrasound. Lateral compartment involvement, multi-compartment involvement, scar endometriomas in atypical locations or complex anatomy, variants of endometriosis like foam, pregnancy with decidualized endometrioma, and malignancy. Refer for an MRI. I would like to end my presentation. Any doubts you can have or ask?
Thank you so much, ma'am, for such a detailed description of the topic. The efforts you have put in making these presentations are evident. Thank you so much, ma'am. Ma'am, there are few questions in the chat box. We can take them one by one.
Few, there are quite a few, I think.
Yeah, ma'am.
31. So we have to start from the first question, I think.
Ma'am, there is a question by Mr. Dr. Deshmukh. What preparation you give for rectal endometriosis? Hello.
See, all I would like to emphasize the diagnostic yield, the diagnosis for a good bowel nodule, you cannot miss even on a TVUS when you do a dedicated protocol. But bowel preparation, yes, it is imperative for lesion mapping, accurate lesion characterization. Here we follow bowel preparation by using either tablet Dulcolax or syrup Dufelac the night before and low residue diet.
Okay, ma'am. Ma'am, next question is, please give salient features of rectal and bowel endometriosis. Again, by Dr. Deshmukh.
So see, before you pitch on the salient features, I would like you all to understand the normal anatomy. The moment you put the probe in the posterior fornix and orient posteriorly, at least 50 bowels, if you see, you will identify. The first thing you encounter is the external sphincter complex, anterior and posterior part, anal canal, rectal ampulla, the wall of the muscularis, the hypoechoic muscular wall will not measure more than 3 millimeter in a normal setting. So once you are identifying this, it becomes a routine. This is how a normal bowel looks. Then deep endometriotic nodule will have its characteristic signature pattern wherever it is seen. It will be hypoechoic, irregular, solid nodule, which will be epicentered in a transgravitating mass, has a blood signal which is obstructed. Clinically, the patient will have extreme dysmenorrhea. That is point number one. Second, because this cavitated, the so-called cavitation represents blood. So the MR is useful in characterizing or adding specificity by picking up the blood signal. And the location usually is antero-inferior to the round ligament, near the gubernaculum attachment. Acum.
Can intermenstrual spotting be a sign of endometriosis? If yes, then which compartment? This question is by Dr. Supriya.
See, still menstrual irregularities corroborating with the inflammatory distribution of the lesion? No, I don't think. Because the inflammatory distribution of the lesion corresponds to the clinical sites of pain. So which compartment, where it will cause? In general, whenever patient come with endometriosis, the most common symptom is severe crampy pain, irregular PV spotting, pain through the cycles and after it, and occasionally pain during ovulation. These are the set of symptoms classically patients with yield of endometriosis have. But intermenstrual spotting corresponding to specific site of endometriotic involvement, no.
Okay, ma'am. Next question is, can scar endometriosis be picked up by ultrasound?
Yes, very well, it can be picked up. It again depends on which area or anatomy. So the most common is previous cesarean scar. Again, the scar endometriosis classically will have pain during periods and after it, intensifying after it. And again, the scar endometrioma is a typical presentation is a hypoechoic solid nodule. The presentation or spectrum of scar endometriomas is also heterogeneous depending on the underlying abnormality. Some have small nodules. It can be in the subcutaneous fat. Some have involvement of rectus. Some have fistulous communication with the endometrial cavity. So the spectrum of scar endometriomas vary, but predominantly it is cyclical pain. Clinically, it is diagnosable. Role of imaging is to map, to again trace the patient for surgical planning, whether it is in the subcutaneous plane or it is intramuscular or it is adherent to the rectus sheath. So scar endometrioma mapping, you tell for lesion excision and decision for the mesh placement and the estimated side of the defect. Not for diagnosis. I think clinically, scar endometrioma patients come with their complaints and point with their finger. Here I am able to feel the point guided tenderness will be there.
Yes. I think, ma'am, last question now. This is by Dr. Anita. She wants to know your comments on pleural endometriosis.
Pleural endometriosis. Again, pain during menstruation, catamenial, during menstrual cycle, the range of pleural thoracic manifestation can be collapse of the lung, large pleural effusion. Here, the role of MRI will come. Lesion, background to that pleural collection, you will pick up blood degradation product.
Okay, ma'am. Ma'am, rest comments are all praising you for this wonderful presentation. And there is one question that do you run some short training courses for practicing reproductive medicine people?
Not yet. Not yet.
Dr. Priya, ma'am, if you would like to say something. Okay, ma'am. In the end, I would like to present my vote of thanks to you. My hearty vote of thanks to our esteemed speaker, Dr. Madhvi Nori, for taking out your precious time and gracing this occasion. And rightly pointed out by you, what mind doesn't know, the eyes can't see. Thank you, ma'am, for enlightening us with your pearls of wisdom. And I would also like to thank Dr. Priya Bhave Chittawar, ma'am, my mentor, who has come up with this great idea of forming a platform where we practicing reproductive medicine specialists.
Priya madam is there. She is there, Dr. Priya.
Yeah. Okay. Ma'am.
She's there, but I don't know.
I think ma'am is muted. Can you unmute her?
Online. Yeah, Priya madam. Priya madam, you can unmute yourself, your co-host. Hello, Priya madam. She had just
thank you so much.
Messaged me.
Audible?
I'm muted, but she can unmute herself.
Yeah, thank you so much, Dr. Madhvi. It was indeed an excellent presentation, and thank you so much for sparing time. And as everybody said, it was such a great experience for all of us who deal with endometriosis day in and day out.
Thank you so much, ma'am. Thank you for giving me this opportunity, in fact.
Thank you very much. And all the participants, this lecture will be available for a week on the MPIFS chapter Facebook page. So if you've missed something or you want to look at something again, it will be available for just a week. So make sure that you visit our page and log in and listen to this again. Thank you so much.
Thank you. Thank you all.
Thank you, ma'am.
Thank you so much. Thank you.
Ashita madam, should I end the meeting?
Yeah.